last few years, I guess the last 4 years, I've been working very closely with the CPHA and the OPHA, and actually with a number of your other associations. We've kind of done some federal letters to federal ministers on a few issues over the last few years as well. But the last 2 years, we've had some funding from the McConnell Foundation, and the 3 organizations together, we've been collaborating on a project where we've been collecting case studies from public health units across the country, trying to get a sense of how they're working on issues that might actually touch on climate solutions, and they might be doing it for population health or health equity purposes, but it also has kind of climate benefits. So we want to kind of get a sense of the strategies they're using and lessons that they've learned. So we've got those case studies, and some of which have been presented so far in 3 webinars. We have 1 more to go. But we've also been collecting the evidence, the health and health equity evidence that links that demonstrates benefits associated with 5 local climate solutions. And those solutions are green space, so kind of thinking very broadly, green space, green buildings, public transit, walkable neighborhoods, and active transportation infrastructure. So today what I'm going to do is talk a little bit about the health and health equity benefits, or quite a bit about those, kind of just summarizing, very high level kind of summary of the some of those benefits, and then talking a little bit give some examples of some of those case studies in terms of the different strategies that public health units are using. And I guess one of the things I'd just like to say is I'm really focused on the immediate health and health equity benefits associated with climate solutions, because I've actually had the opportunity to do a lot of work over the years on issues like coal plants and fuel standards and active transportation, where what I've actually found is that while sometimes these policies are being promoted to address climate change, often the arguments that kind of bring the population on side, or the public on side, and decision makers on side are actually the health benefits, because they're very immediate. They happen in the jurisdiction that are that's taking action. And so my experience, when I was at CAPE, I actually was involved in kind of a campaign to phase out coal plants in Alberta. And we really focused on the air quality health benefits that are very immediate, because those resonate more with people than kind of, I think, the longer term benefits of climate change. I think sometimes people have a harder time envisioning that happening. And so today, kind of what I'm really focusing on is, rather than the health impacts of climate change, were extremely important, and climate change adaptation, which is, I know public health is involved in and is very important, but kind of talking about how we as a public health sector can really help to fight climate change, to kind of help move things in the right direction that we need to move in the coming years. So I'm not going to get into the health impacts as a whole, but just a reminder for all of us, and I probably don't need to say this to people on the phone, because I'm sure many of you follow this issue as well, but just a reminder that in Canada, while we are feeling the impacts in the last several years, we are starting to see fairly significant impacts. On a global scale, climate change is already producing catastrophic impacts. So at 1.2 of global warming, which is kind of where we're at right now, extreme events such as heat waves, hurricanes, and droughts are actually claiming the lives of hundreds of thousands of people each year. They're increasing food insecurity for tens of millions of people. They're escalating conflicts and forcing people to flee from their homes. So these are the refugees that are at the doors of, the Europeans and of North America, that are leaving countries that are really, really suffering from climate change. And a lot of that just has to do with geography. We're fortunate that we are not in the parts of the world that are heavily hit. We are starting to feel it, and we will feel it more in coming years, but we have not felt it nearly to the extent that many countries have. Also, just pointing out, in the fall of last year, the Chief Public Health Officer came out with a report on climate change, where she talked about the importance of climate change and the importance of climate change adaptation work that public health is engaging in, kind of trying to minimize or mitigate the impacts that climate change will have on human health. She also made it kind of a clarion call for us to be involved in the prevention of climate change, to help fight climate change and help reduce greenhouse gases. And that's kind of what we're going to be talking about today. So just a reminder for all of us that the Intergovernmental Panel on Climate Change came out in 2019 and said to prevent 2 degrees of warming, which many people feel would actually make the world unlivable within decades, we need to cut greenhouse gases by 45% by 2030 and reach net zero by 2050. And when people talk about that, that's an average. What people, when you talk to, the experts on this issue, they would actually say that the countries that have been heavier emitters should actually be moving faster than that, and that the low emitting countries, they don't need to work on this nearly as fast. One of the things that many of us in Canada do not realize is that we are actually one of the top 10 emitting countries and have been for decades. And I think sometimes we aren't aware of that in Canada. So just a little kind of note here about where are the greenhouse gases coming from in Canada, and they're coming from many different sources, but this is looking, and there's different ways to slice the pie, but this is the way that Environment Canada looks at it. So if you look at the blue line on the right there, that's the oil and gas sector. So what you can see is that the oil and gas sector is responsible for about a quarter of our emissions as a country. That is not us using oil and gas. That is actually the extraction and refining of oil and gas. That's the oil and gas sector. Then if you look at the brown line, that's the transportation sector. And it's, again, responsible for about 25%. And then if you look at buildings, that's the gray line, and it's about 13%. But what people say is that a lot of the electricity that we generate in Canada is used in buildings. And so they say when you combine those two, when you actually look at all the energy in the building sector, it's about 18%. And then electricity sector, it's 11%. Now, if you look at the red line, that's the electricity line, you can see that the emissions have come way down in there. And that's because of the phase out of coal plants in Ontario and because of the phase out of coal plants in Alberta. Those numbers are coming down. And so that's an area of really kind of where we've had a lot of success. The reason I'm pointing this out is because working at a local level with our municipal partners, or if you're part of a municipality, as we are in Ontario often, with other departments that work on these issues, there are a few issues here that we can really have some influence on at a local level in terms of the transportation sector, the building sector, and to some extent the electricity sector. So throughout this report, throughout this presentation, I may talk about health equities and vulnerabilities, and just so we're clear about what I mean by that, we know that climate change will affect all of us and is to some extent affecting all of us, but we know that it will amplify the health inequities and vulnerabilities of certain populations. So just in terms of talking about who we're referring to there, young children, older people like me, those with pre-existing health conditions such as diabetes or asthma or cardiovascular disease, these groups are just physiologically more sensitive to environmental stressors such as extreme heat and air pollution and toxic. So this group, any kind of climate change impact that kind of touches on those stressors and increases those is going to be harder on those populations from a health perspective. But we also have a number of populations in Canada who are structurally disadvantaged. And what we mean by that is these are populations that are greater risk of infectious diseases, chronic diseases, premature deaths, simply because of the social or economic conditions that they live in. So these are people who are have low-paying jobs or poor housing conditions, or perhaps can't afford a house, or food insecurity. And we know that these populations will be more sensitive, again, to climate change health impacts, simply because their health has already been compromised by the other situations that they face in their lives. One of the things in public health, we've talked about this often, we use the term social and sometimes social and environmental indicators of health. But we haven't always said in public health that we're trying to say more is that we recognize now that those disadvantages are often the result of interpersonal and systemic biases or prejudices, such as sexism and racism and colonialism, sometimes that are kind of baked into our attitudes or baked into our systems as a society. And I think a good example of that is that many of us can relate to if we've ever been involved in municipal kind of issues, built environment issues, is how often low-income neighborhoods are lacking in parks, or they don't have good active transportation infrastructure, for example. I think I've certainly seen those examples in my career. But these populations can also experience greater exposure to climate change impacts on top of being sensitive. And that's because, I think we just need to think about a family living on a low income in an apartment building that doesn't have air conditioning during an extreme heat wave, or a person who doesn't have a home out on the street during an ice storm. And the other challenge that these populations face is that they may not have the resources to protect themselves from climate events, extreme events, or even to recover from those events. And I'm thinking about a taxi driver. I was talking to in Ottawa once, and the Ottawa River had once again flooded. And this taxi driver was saying that he had a friend who had now had his home flooded twice. And after the first event, couldn't afford insurance. And so now it's flooded, his home had been flooded again. And now he no longer had insurance and he didn't know what he was going to do. So I think this is the kind of thing we're talking about. So in terms of the transportation sector, there's many different health arguments for, improvements to the, changes in the transportation sector, but the two really big ones that have all kinds of evidence behind them, and where we actually kind of evaluated the and assessed or kind of estimated the health impacts, the value of the health impacts, is looking at air pollution is one. And already in Canada, we know that, air pollution causes about 15,000 deaths per year in Canada, and that it's responsible for about $130 billion in health-related costs. So health-related costs includes things like lost time. But traffic-related air pollution, this is actually the air pollution that kind of hovers around high-volume traffic corridors. So the little map you see here, this is the GTA with kind of modeling for air pollution. And what you're seeing there is how air pollution is really concentrated around the 401, the 427, the Gardiner Expressway, are big, huge highways here. And so we know that there's this big kind of tunnel of air pollution, and there's hundreds of studies have looked at the impacts of traffic-related air pollution, and they've documented a broad range of health impacts, everything from increases in the rates of asthma in children, and the rates of asthma exacerbations, and cardiovascular disease, lung cancer, premature death, strokes. All kinds of health impacts have been very clearly linked to how close people live to these high volume traffic corridors and the air pollution that's associated with them. And we also know now, like more recent evidence actually says that this air pollution is likely to cause childhood leukemia and lung cancer in adults, and may actually cause breast cancer in adults as well. So the other health kind of argument that can be used for changes in the transportation sector, or the other health argument for changes, is looking at physical activity and health. So we know that physical inactivity is associated with an increase in all kinds of kind of chronic diseases. We know that chronic diseases contribute to 150,000 premature deaths per year, and that they are kind of overwhelming our healthcare system. With people who have chronic diseases are really, demands a lot of our healthcare system, and is also causing a lot of harm to people's lives, and kind of taking away kind of the value of their lives, the quality of their lives, because of these chronic diseases. And so physical inactivity, one estimate said that inactivity of people in Canada is actually costing about $7 billion per year in health-related costs, just from 7 chronic conditions. And so we know that physical activity is something that can really reduce chronic disease, and anything we can do as a society to increase that is really valuable. So now kind of turning our attention to what are 3 kind of approaches that we can use in terms of the transportation sector to improve health. And what I'm really interested in here is that we have opportunities with these 3 kind of, climate solutions. They all reduce greenhouse gases, they all reduce air pollution, they can all increase physical activity, and they can also address health inequities. And so to me, these are like the golden bullets for public health. So first of all, public transit, people looked at this for years, that, if you get 28 people in one vehicle instead of 28 vehicles on the road, you can reduce climate change emissions, you can reduce air pollution. And there's been a number of modeling studies that have really demonstrated that. There was one done in the Greater Toronto and Hamilton area, where the medical officers of health actually led this study. And they just looked at improvements in the regional transportation system here, and they estimated that if the province were to go ahead with these improvements, it wasn't like a brand new system, just improvements, that new plan could actually produce $2 billion per year in health-related benefits by reducing air pollution and increasing physical activity. So we have all kinds of studies that have demonstrated that kind of thing in different locations. But the other thing with public transit is, from a health equity perspective, is that public transit really increases access to jobs, services, recreational opportunities for all kinds of people who can't drive because they either can't afford a car, or they're not too young to drive a car, or too old to drive a car, or they may not be able for other kind of different abilities reasons. So a lot of people in our country can't drive, and yet we kind of design our cities as if they can. So public transit, it really can increase health equity by giving people opportunities that they wouldn't have if we didn't have good public transit. And the other thing is that CAA estimates that it costs $6,000 to $13,000 per year to own and operate a car. And so anything that we can do to prevent or mean that somebody doesn't need to have a car, our family doesn't need to have a second car, can mean all kinds of savings for a family, something that we can all appreciate, but certainly for a family living on a very low income, that's extremely important. And then we also know that communities that are built around good public transit actually tend to have fewer vehicle-related deaths per year, simply because I think the thinking is that people who are high-risk drivers are more likely to go home by transit. If you're kind of going out with your friends for the evening and you can take transit home instead of getting in a vehicle when you've been drinking alcohol or something, that's not an opportunity that's available to people in communities that aren't well served by transit. So the second kind of, climate solution that, many of us kind of look at that also has health and health equity benefits is active transportation infrastructure. So hundreds of studies have looked at the benefits of active transportation in terms of encouraging people to walk more and cycle as a mode of transportation, not just for fun or not just for physical, not for exercise, but actually doing it as a mode of transportation. And we found that this is actually the best way to get the greatest number of people more physically active, is to actually build it into their day. When we talk about infrastructure, like active transportation infrastructure, we're talking about separated bike lanes, safe bicycle parking, pedestrian bridges, benches so that people can rest when they're walking, good lighting, sidewalks, traffic lights. All of these things have been demonstrated to increase the likelihood that people will walk and cycle as modes of transportation. And so the number of studies have looked at this and have demonstrated that the more that you can shift people into these two modes, like walking and cycling as modes of transportation, we can reduce greenhouse gases and improve air pollution, or decrease the emissions of air pollutants. But it also increases safety and it increases physical activity. And so you get all kinds of health benefits in terms of chronic diseases being reduced and air pollution impacts, et cetera. The other thing is that with active transportation infrastructure tends to be more important in low-income neighborhoods, where again, you might have families or individuals who actually can't afford a vehicle. And often these neighborhoods are not well served with local amenities like grocery stores. And so actually to kind of provide good infrastructure to these communities is actually more valuable, because these people are actually more likely to need that infrastructure or more likely to use it. So I want to focus on just a few studies for here, just to kind of demonstrate the argument. So a long-term study was done in the United Kingdom, and they looked at 22 communities. They followed 250,000 people over 5 years. And what they found is 90% of cycling commuters actually got all of the physical activity that they needed, that was recommended, by healthy guidelines. They found that 50% of people who were walking, commuted by walking, were getting the physical activity they needed to maintain good health. And then when they looked at the impacts in terms of chronic disease and premature deaths, they found that people who commute by bicycle, they had a decreased risk of cardiovascular disease, cancer, and premature deaths from all causes. So cycling is like commuting by bicycle is actually an incredibly healthy thing to do. And then commuting by walking, they found that these people had a significantly lower risk of cardiovascular disease, provided they were walking at least 2 hours per week. And then one other study, and this was a modeling study where, the Midwestern United States, they said, so what is this actually worth? If they looked at a population of 31 million people, and they said, if we could eliminate all the vehicle trips that are less than 8 kilometers in this region, what would that mean from a health perspective? And they said, let's eliminate all those trips that are less than 8 kilometers and get half of those people to take their bicycles instead. They found that they could produce $7.35 billion in health-related benefits per year. because of increases in physical activity and reductions in air pollution. So just to kind of get a sense of the value of those. So walkable neighborhoods, you've kind of got the same benefits here in terms of chronic disease that you get from active transportation infrastructure. But when you're going about making these changes, the often different people within a municipality who are working on these issues and kind of different approach. So with active transportation infrastructure, in my experience in Toronto and sometimes in other municipalities, you're dealing with transportation planners. You're dealing with a different thing. You're talking about how we design our roads. With walkable neighborhoods, we're talking to land use planners. How do we design our communities? How do we design our neighborhoods? So when we talk about walkable neighborhoods, we're talking about a number of different characteristics. And I just want to say again, hundreds of studies have looked at what it makes a walkable neighborhood and what impact do they have on greenhouse gases and human health. So, here I'm talking very high level here, just pulling from a number of studies that are out there. People talk about the 5 Ds. So a walkable neighborhood has to have a density of people. You have to have a certain number of people living within, a certain area to make it efficient for public transit, to make it affordable for a restaurant or a grocery store to be there. And then you need a diversity of land uses. So if you live in the suburbs and you have to travel 20 minutes to get to a restaurant on foot, it's very unlikely that you're going to do that. So what we found is if you have a diversity of land uses, things like grocery stores and banks and libraries and homes all grouped together, a diversity of land use, that people are more likely to walk and cycle than take their vehicles. And then design refers to the design of the streets. We have to design our streets in a way that they encourage people to walk, and we have to design the community as well. And then destinations. If there's common destinations that people have to go to, their jobs, their schools, places that people go to on a regular basis, if people can access those by walking, cycling, or transit, then that makes for a more walkable neighborhood. They're less likely to drive. And then again, distance to transit stops. If transit stops are within a walking distance, people will use transit. They'll just more likely to do it. At some level, this is common sense, but at some level, it's all been demonstrated with various studies. So walkable neighborhoods reduce greenhouse gases because people are using their vehicles less, they're using transit more. An increase is walking for transportation. It's been associated with reductions in weight, in the levels in metabolic disorders, in diabetes, in premature deaths. It's been associated with reductions in air pollution and with improvements in health equity by increasing access to essential amenities, but also by improving health in more direct ways. And so what we've seen with some of the epidemiological studies that have been done is that the health benefits are actually greater for low-income populations than for higher income populations. So here's just one study, one of many, but this one is quite powerful. It's a Canadian study. They followed 1.8 million people in many communities across Canada over 15 years, and they found that those who live in the most walkable neighborhoods were 9% less likely to die from cardiovascular disease, 13% less likely to die from strokes, 3% less likely to die prematurely from all causes than those who lived in the least walkable neighborhoods. So these are really significant findings and significant reductions just by encouraging, creating neighborhoods that foster walking. The other thing they found in this study is that those that lived in the most walkable neighborhoods who had little education, who lived in low-income households or lived in highly deprived neighborhoods, so those 3 different categories, were 9%, 15%, and 25% respectively, less likely to die prematurely from cardiovascular disease than similar populations living in the least walkable neighborhoods. So this is where they're kind of saying the benefits are actually even greater for people who come from those socially disadvantaged groups that we were referring to. And then kind of changing tactics. So that was walkable neighborhoods, public transit, active transportation. 3 things that reduce climate solution, that reduce greenhouse gases while also improving population health and health equity. So shifting gears here, I'm going to now look at green buildings and green space. And the one health impact, there's a number of different health impacts for both, but one that they both have in common is extreme heat. And so I just want to talk a little bit here about, what we're with extreme heat being something that's increasing with climate change. One study looked at 26 Canadian studies, estimated that extreme heat can increase premature deaths by 2 to 13%. So that we're talking about a fairly significant number. It sounds small, but when you think about the whole population, we're talking about a number of people dying prematurely because of extreme heat. The BC heat dome in 2021 took the lives of more than 600 people in that 1 week. And the researchers who looked at the issue found that deaths in the community, when they say in the community, they didn't include long-term care facilities. But deaths in the community increased by 440% that week. And they found there were much higher death rates among people 65 to 74. I think the people older than 74 were probably in long-term care, so they didn't see the death rates there. It was much higher in low-income populations, higher in homes that lacked air conditioners, higher in neighborhoods that had less greenness, fewer trees, less grass, fewer parks, that kind of thing. And it was also higher in communities that had very high building densities as well as being less green. So just looking at green buildings and building retrofits here. So the International Energy Agency, which is actually quite a conservative organization, it's been very slow to kind of recommend things that I think other people feel they should have been recommending. But when they actually looked at Canada, they said that Canada could actually reduce all the greenhouse gases that's in oil, like they come from the burning of oil and gas used in buildings by 30% by 2050. That was their estimate looking at us. They also said that energy demand for space heating could be reduced by 85% by 2050. Simply by improving the building envelope, which is kind of what we all think of as kind of, energy efficiency, and by using heat pumps. And we know that green buildings and building retrofits can also reduce air pollution because oil and gas, the burning of oil and gas in our homes to heat our homes, etc., that releases nitrogen oxides, which contribute to fine particulate matter and ground level ozone, as well as some other pollutants. So just to touch on heat pumps, because they're talked about there, but there's something called cold climate air source heat pumps, which is a mouthful. But these heat pumps, they're kind of a new generation of heat pumps that can actually operate at temperatures as low as negative 25 degrees. And so what's coming out now that people are actually saying that we can actually completely replace conventional oil and natural gas fired heating systems with heat pumps. And the beauty is that a heat pump air conditions in the summer while heating in the winter. So it's one technology that does both things. And that apparently with a heat pump, you can actually, it requires 70% less energy than conventional home heating. And so there's significant energy savings for people, or as well as like kind of cost savings. And also that when the electricity is coming from renewable energy sources, it would in some provinces like BC, heat pumps can actually cut greenhouse gases from the heating and cooling of buildings by 100%. So this is like a huge thing from a greenhouse gas perspective and a huge thing in terms of cost savings for individuals. So just to kind of go back here a little bit about buildings. Indoor environmental quality is actually a really important kind of indicator, has a significant impact on human health. It actually can increase the risk of cardiovascular disease, strokes, premature deaths, asthma, respiratory diseases, if you have poor indoor environmental quality because of issues like extreme heat and extreme cold, viruses and bacteria, molds and dampness, air pollutants and toxics. For a variety of reasons, poor indoor environmental quality is quite a concern. And again, we know that it can actually amplify health inequities because these populations, because of reasons mentioned before, might be more sensitive to some of these extremes or these exposures, but they're also more likely to live in poor in buildings that have poor IEQ. And again, they're less likely to have the resources to correct that problem and to protect them from climate-related events such as extreme heat. So what they find is that when we build green buildings and we do building retrofits and we do them properly, we can stabilize temperatures, we can reduce mold, we can improve the indoor air quality, and that produces improves health. And there's a number of studies that have looked at this in both multi-household buildings, I can't remember the quite word for that, but as well as individual buildings. And so it can also reduce energy poverty by simply reducing energy costs for people. And I think kind of built in here is just being really clear that if we kind of shift over to heat pumps or some other way of cooling buildings, then we can actually protect people from extreme heat as well as heating their homes. And so shifting now a little bit to green space. So we know that green space can kind of be a sink for greenhouse gases, but a number of studies have actually demonstrated that green space can actually reduce the temperatures, so it can kind of, with the urban heat island effect, it can reduce the temperature in a community, and it can actually kind of reduce the levels of air pollution, so it can clean and cool the air. And that the impacts of this can actually be felt very locally in a small little community around a park, for example, but collectively at a community level as well. And that it's particularly important for low-income neighborhoods, again, because these neighborhoods tend to be lacking in green space and tend to be more heavily impacted by things like extreme heat. So the other advantages or health advantages associated with green space is that there are a number of studies now that have looked at other mental and physical health benefits. They have found that living near greenness, and they say greenness sometimes because there's different measures. Sometimes it's just grass, sometimes it's trees, sometimes it's parks. So there's different measurements for greenness and green space. And so that makes it a little bit hard. There's all these studies that have used different kind of parameters to measure greenness. But what they're finding is that it seems to be associated with decreases in stress, a decrease in ADD symptoms in children, particularly in depression. It seems to be associated with healthier birth and healthier weights for children, improved cognitive function in children, decreased risks of diabetes and premature death. So there's all these health benefits that seem to be associated with green space and greenness. And I think this is one of those things. I know for me, I go for a walk every day, and I go for that in a green place. And I know that I can feel all these benefits. And I'm sure that we've all had that experience, that sometimes we need epidemiological studies to prove what we kind of intuitively know. But over the last decade in particular, there's been a lot of studies that have looked at green space, and there seem to be a lot of mental and physical health benefits aside from its cooling impacts. So one long-term study that was done in Canada, they looked at 1.3 million people, and they measured greenness within 250 to 500 meters of people's homes. And they found that it seemed to be associated with a decrease in premature deaths from 6 different causes by 8 to 12%. So the epidemiologists that are doing this work are saying that this is significant, incredibly important findings. Again, we're still kind of the early stage for this kind of evidence, but it's kind of starting to look like we have a very positive impact on human health here. And then in terms of greenness and health equity, and again, we need studies to demonstrate these things, but intuitively, I think many of us know that often low-income neighborhoods are less likely to have as much green space as high-income neighborhoods. And that's what this study found that looked at Montreal, Toronto, Vancouver. It found that materially deprived neighborhoods were more likely to have higher levels of air pollution, to be less walkable and less green. So kind of demonstrating, or kind of, with numbers, kind of what we kind of intuitively kind of understood. So what I want to shift to, so that's kind of the 5 climate solutions and many of the health and health equity benefits that can be associated with them. So what I want to shift to here now is just look at a number of different case studies that we kind of got over the last year. And I want to be really clear, these were kind of randomly collected. This wasn't, we kind of put out a call for case studies and people came forward. So it's not representative of public health, but they seem like kind of really good examples that might inspire other people, and maybe other public health units are already doing that. If so, that'd be really great to hear. But I thought that they're public health departments that seem to be doing some really great work. So I just want to touch on a few and hope that I had a situation that might be recognize that public health units have really different contexts and have very different relationships. In Ontario, we have public health units. Some are actually embedded in regional government, some are embedded in local municipalities, like actually a city, and some are actually independent and with boards that have representatives from 15 or 20 different communities that they capture. And then in many other provinces, it's an arm's length relationship to the province. So I know that there's very different situations, and so I've tried to capture different situations that might kind of relate to some of your experiences. So Ottawa Public Health, it's a department of the City of Ottawa. What they've done over the last several years is they actually co-located 2 of their public health staff in the planning department to help develop the new official plan. So they actually had one staff was really focused on building the 15-minute neighborhood. So a neighborhood where you could walk to everything that's common, public transit to all the important amenities within 15 minutes of your home to really kind of create walkable neighborhoods throughout the city. So one person was really focused on that work, and the other staff was really working to build into the new official plan for the city of Ottawa, resiliency to extreme heat. And that actually took her into, involved the development or co-development of a high performance development standard for buildings. So this is basically a green building standard. And so this was really interesting. They did this over 3 years. And so they were involved in everything right beside their planners, and they actually reported directly to the planning, the planning director, as well as to their medical officer of health. So it was kind of really trying to bring public health evidence into the process and trying to be at every table that planners would normally be at, and making certain that health concerns were being considered all the time. And then the high performance or the green building standard, they really built into there that buildings should mitigate health impacts for occupants as well as residents. So trying to kind of say that the residents around the building, that they should try to kind of think about the impact of the building on local residents. They wanted to have things like the fresh air intakes would consider where traffic related air pollution is, so that they would try to make certain that those intakes are up high enough or on the other side of the building, so that they're not just kind of sucking in air pollution from high volume traffic corridors. And they also looked at things like community energy planning, sustainable roofing, soil volume, so that people can actually grow trees on their property, and a number of things. So that's really interesting. In Vancouver, so in Vancouver Coastal Health, it's an arm's length agency of the province, and there they've actually established an healthy environments team that tries to fold social and environmental determinants of health into their built environment work. So they try to bring both those things. And so they talked about, because they're arm's length, that they work, very much with Vancouver, and they will go and actually meet with key staff and key agencies such as TransLink, which develops, transit systems. And they will actually kind of go and meet with them and say, what are you working on? Here's our health interest. How can we help? And then they will actually kind of go and provide formal comments on proposals and plans, and they'll provide comments early on in the stage before there's even a proposal. And then the medical health officer there will actually go and depute to political bodies like, city council, and support any proposals that are going forward that they feel are really supportive of public health and health equity. And so they gave kind of an example that they did this with TransLink, and they went in and they talked about the physical activity benefits, that the social equity benefits, etc. And they did this, informally, formally, like as other people do, and then, politically kind of doing it to really kind of bring the weight of health to those processes. In Niagara region, the public health department there is part of the regional government. And what they did there is they actually, the medical officer of health there actually managed to get the whole region to agree to a health equity informed planning process. And what that means is that every corporate decision, so this is for the municipality as a whole, but anything applying to the work that the corporation, like the region itself, is doing, that it has to go through a health equity assessment process, a health, and right now public health is actually, this is brand new, but right now public health is actually managing that process. And so there's 3 levels to what they're calling this health impact assessment. There's a rapid, intermediate, and comprehensive one. And the rapid one is just a desktop exercise. They use secondary data that's readily available, and they go and they talk to different people involved with the project, and also to other public health staff who might have expertise. And they kind of assess whether or not we need a more in-depth kind of assessment. And then they kind of just, there was one example that we looked at where they done this work. And the question they're always asking is, will this project, is there a potential for this project? So let's say the reconstruction of a road, to amplify or mitigate negative health impacts on priority populations for each social determinant of health. And so that social determinant of health would be, the transportation. There's all these different categories, and that's what they're trying to do. For one road reconstruction project that was near 3 schools and 4 adult living facilities, they actually kind of came back with some recommendations and said, well, when we look at this, you actually need to do more to increase active transportation and ensure the safety for pedestrians and cyclists, and to ensure that there's access to services with real consideration for the fact that you have a lot of children and these people in adult living situations who have to be accommodated. So that was kind of their one example. And then in Peel Region, we have Peel Health as a department in Peel Region, and they've been working really closely with the people in other departments on, let's say, the Urban Forest Working Group and then the Climate Change Steering Committee for both the local municipalities like City of Mississauga as well as the region. And what they've been doing is at every stage, they're trying to bring in health evidence about the benefits of green space and of trees. And so at each stage, they're trying to raise the health benefits and the health equity considerations that they think should come to that. And so one of the tools that the Peel region came up with this committee that included public health was a tree planting prioritization tool. And so this tool is quite complex and it has all this data in it, but the idea is that partners can actually go in and they can put in information like where are the low income neighborhoods, what are the trees like in that area, and they can put in other factors to actually prioritize where the trees are needed most. So public health could actually, it could be used to identify a low-income neighborhood that has very, very little green space as an area to be prioritized for tree planting to address health concerns in that community. And then just two more. Let me just see here. I've got two more. Heat pumps. So Island Health is Vancouver Island Health Authority, called Island Health for short. They actually, and this one applies more to those of you who might work in smaller communities. So this on Vancouver Island, they have many, they're responsible for many small and remote communities. They do have a few big cities like Victoria and Nanaimo, but they have a number of very small and remote communities. A number of those are Indigenous communities. And so they've set up a healthy built environment portfolios as well, but they had to approach it very differently because they didn't have they couldn't focus and have the team the same way they did with Vancouver. So they get support from the province for policy positions and resources. And then they had one healthy built environment coordinator, and her job was to actually help build capacity among environmental health officers and to support them. And then they were kind of going out to the community, and they were really encouraged or instructed to work with community health networks that have been set up over time. And so these community health networks would include elected leaders, First Nation reps, it would include community groups, staff from local municipalities. And the idea is if there wasn't a community health network, to help set one up and then to meet with them and to really work from the interests and the concerns of that community and find ways to really support them, whatever issue they were worked on, whether it was an air pollution or if it was that they needed more active transportation infrastructure, to kind of find out what their concerns were and then to really support them by bringing health evidence and a health equity perspective to the table. And one of the examples they gave was that with Cowichan Valley Regional District, where they had a community health network, air pollution was a real concern in that area because you had a lot of people using wood to heat their homes and doing a lot of open burning with wood. And they had a real air pollution problem because they kind of had mountains with the valley. And they ended up developing this whole program that included the swapping out of wood stoves for heat pumps. There were other elements to it, educational as well, but that was kind of one of them, which I thought was a great example of kind of public health helping to support the movement of a building retrofit that was good for health. And it was good for air pollution and climate change, but it was also going to be good for addressing heat concerns that have now become an issue in BC. My last example here is Simcoe Muskoka District Health Unit. And again, this is a local public health agency with an independent board of health that has to serve 26 small municipalities. A few of them aren't so small, but 26 municipalities. And so these people, they've got to deal with a lot of different communities. And so they've got a three-pronged approach to climate health. One is that they tried to build climate change mitigation and adaptation into all of their kind of policy work that they were doing around the built environment. And then they've also been trying to develop a collective impact approach by establishing a climate change exchange. So this has 40 members, and it's got people from the hospitals, local hospitals, and school boards, and maybe some of the big employers, and all these different groups in these 26 communities who get together and they share information, and sometimes they collaborate on projects and sometimes they look for funding together. But basically it's all these people trying to figure out how to respond to climate change and how to do climate change adaptation, but kind of learning from one another and sharing information with one another across the city. And then the third one is trying to reorient the public health practice. And they say they're still doing this, but what they're trying to do is do training within the public health department so that everybody is thinking about climate change mitigation and adaptation as a part of their work. So saying that whether you're a health promoter or health environmental health officer, whatever your job is, you should be thinking about, is there something that I should be raising from a climate change perspective, and trying to get people to build that into all of their work. And the last piece here that's really important that they've done is when they did their work, they did a deep dive into climate change adaptation processes across the country, and they did a deep literature review. And what they realized is that that research didn't really capture what was happening in Indigenous communities. So they went out and they contracted an Indigenous consultant to do work research on Indigenous perspective on climate change adaptation. Actually came up with a second report from this person to really capture the experience and knowledge of Indigenous communities. And now they're trying to figure out how to kind of fold those two kind of pieces of research together to inform their work. They've also been sharing that work with other public health units across the country. So that's kind of it in terms of the case studies. There were other case studies, but I thought that those were kind of a nice selection. And then in terms of the overall themes that we saw with the different case studies is one that a few of these public health units that we were looking at were doing climate change mitigation, like really being aware of, oh, this will reduce greenhouse gases, while also doing their health and health equity work. But a number were not, but they all recognize that it was. Like, people might be working on active transportation. They say, oh yeah, we don't really talk about climate change mitigation, but we're well aware of the fact that this will reduce greenhouse gases. And so kind of just that a lot of these people are doing this work. Some are recognizing it officially and formally as a climate change mitigation work, but some are not. Every one of them said that sectoral collaboration is essential if you want to shift public policy in local communities on any of these issues. And so by that, they were saying, in a large community, like Toronto, Vancouver, and Peel region, it's working across departments, working with the planning department, the transportation department, the transit authorities. In smaller communities, where it tends to be kind of a smaller, it's working with all the other people in the community, and maybe with communities beside them, like if there's an Indigenous community, kind of including them where there might be an overlap or intersecting kind of interests. They all talked about the need that when you are engaged, when you're talking about, like, at one level you can talk about health equity at a high level policy level, but once it gets into implementation, you need to go out and you need to engage disadvantaged populations to make certain that what their needs are and what they feel would be useful to them. You have to engage those people, and you have to do it in a really respectful way. The other thing that they all said was that senior management support is pivotal. It all reflected different ways, but they were saying if you're going to start working across sectors, there's times when it's really important to have somebody from senior management talk to somebody at a higher level over here, so that your views and your input is being taken seriously, and so that people here know that you have the support of a higher level over here. And so that looked different. Like in Vancouver Coastal Health, that was the medical officer or the medical health officer coming to a city council meeting and saying how important this transit proposal was. In Ottawa, it was having an agreement between two departments that these staff were going to report to both departments, kind of really recognizing that health was really important to planning, and both departments agreeing on that premise. They all said that if you really want to be successful in making policy change at a municipal level, and these, kind of really having influence on these kinds of issues, that it requires cultivating relationships in the community or across departments, across sectors, and that requires committing resources. A few of them mentioned that specialized training can be helpful, and it kind of noted that in Ottawa, the two people that were involved with the official plan, one was actually a planner, a land use planner. The other one had specialized planning with kind of in geography and GIS systems and that. So they had specialized training, and they felt that helped them to be more effective when they're kind of working on something like the official plan. In Vancouver Coastal Health, they had people who were trained as epidemiologists and people who had specialized training in planning as well. It requires increased and sustained funding for public health. And again, people didn't say this all the time, but it was inherent in their experiences. A number of health units I asked to interview said that they couldn't because the person actually wasn't at their desk anymore. They were still working on the pandemic. And people were saying that during the pandemic, much of this work just went undone. And that was happening in large cities like Hamilton, as well as in small communities. And so I think the inherent message or the implicit message that we heard everywhere was that this important work is really important, that public health is being stretched to the limit and that we need increased and sustained funding, and that funding really needs to reflect kind of acute situations like the pandemic, but also kind of this growing need to address climate change from an adaptation and a mitigation perspective, and really recognize that public health can have an important role on both those things and has a very important role to play, but they need to have the funding and the resources to do it. So that's it.
Awesome. Well, thank you, Kim, for this presentation. It was super informative. I noticed a number of things in your presentation, like specifically the point about reorienting public health practice on, I think, the second last slide. Like those of us, in public health, we do know about some of these things, but I think your presentation is a reminder that we should be advocating and educating in our work when it's possible. We can be a part of that intersectoral collaboration. And so, yeah, if we're doing land use reviews, for example, we should keep these things in mind: climate change reduction and improving health and health equity. So we'll open it up for questions. If anyone wants to come off, unmute themselves, or you can ask questions in the chat. I know we have one asking for the PowerPoint, and we will be sending that out.
I'd just like to say that I'm also happy just to have comments from people. I mean, I do appreciate that the case studies that we looked at are just little samples of like the great work that's being done by public health across the country. And I will also say to people that some of this documentation, strategies, and lessons learned is really intended for people that many of you work for. We recognize that I think that there's probably among public health professionals, many of us know what needs to be done, but we often don't have the time, the resources, or the authority to do it. And I think at some level, I think we're kind of hoping that I think we need to do, like maybe some of the associations across the country need to do some advocacy to get the resources that people need, but also that, maybe there needs to be more discussions about the important work that public health can do if staff are given the opportunity to do it.
Mm-hmm. Kim, if you hit stop sharing, then everybody won't see my face, which is fine. And then if you, we do have one question in the chat. So Michael said, all the smoke this year has made me think I should not go outside and be active. Any comment?
Yeah, and yes, absolutely. Now again, it depends on your health, but absolutely the smoke, the air pollution. I just want to say, and I say this as Hamilton, so I don't know if people know this, but Hamilton used to be a place where we had really bad air pollution. But I mean, here, if we get an air quality health index reading of 3 or 4, we consider that to be poor health, poor air quality. You guys out in BC and Alberta have been getting levels that are 10 plus on the air quality health index, and you've been getting that for days and weeks at a time. So we're talking about air pollution that can be harmful to everybody. And so for me, when I was out in the Jasper National Park and we saw that smoke, my husband and I were not doing, we were going on walks, but we were not doing kind of really steep walks, and that we were really being careful, partially because we're in our 60s, but partially because, like air pollution like that is not good for anybody. So even if you don't have asthma, but if you've got somebody who's got any kind of pre-existing condition, it can be very dangerous. And I will say, when I was at CAPE, I did work with healthcare, a number of emergency physicians, and they did say that with wildfire smoke and with extreme heat, they saw all kinds of cases coming in to the doors. And asthma exacerbations among little kids was a big one for wildfire smoke. And for extreme heat, it was all kinds of things, usually older people, but a lot of times it was, they were having people coming in with heat exhaustion, heat stress, that kind of thing. So Yeah, I think we have to take these things more seriously than we do. I know for me, I have fights with my husband and my son all the time because they seem to think that they're healthy, that they don't have to worry about it, and it's not the case.
Mike Adams shared a link in the chat that is a BC CDC article. Smoky skies in BC can create health problems for some. So yeah, worth checking that out. Did we have any other questions?
Or comments?
Yeah. We have a question. I was wondering, is the healthcare sector looking inwards towards itself in the area of procurement and waste management that significantly contributes towards GHG emissions?
Yes, they've actually got a lot of money over the last few years. Because I'm kind of working more with public health the last few years. But when I was leaving CAPE, we were doing a lot of advocacy for money to kind of work on that kind of thing. And I understand that they got quite a bit of money and they're working with the University of Toronto and that the whole program going on now, that they're really trying hard to reduce their own waste and their own energy waste. And I don't know how extensive that's been, but I know that there's a number of people working on that, and that, you know, physicians that I was working with at CAPE were really aware of the waste and just saying that it's incredible. So they did recognize, and I think that when you slice the numbers differently, the healthcare sector is supposed to be responsible for 5% of our climate emissions, because, you know, people are saying you'll be kind of heating a whole hospital 24 hours a day, even if there's nobody in the like in many parts of the hospital, right? So I think they saw that there's huge opportunities to reduce their energy use in hospitals. So I think some of that work's starting. Anybody want to offer any of the great experience they've had while we've got the moment here, or like put it in chat so that it can be shared?
So Isaac said, how can we involve active transportation if there is no stationary office? I'm not
sure that I know what that means exactly.
Yeah, I'm not quite sure. Isaac, do you mind just maybe explaining that a little more, or coming off mute, or just typing it in the chat? Like, do you mean because more of us are working from home?
Oh, or maybe even if you're traveling a lot, like I think
if traveling a lot.
Yeah.
You hear me now?
Yeah, and I don't think when I'm talking about this, I don't think we're talking so much about you guys per se, but it's more, you know, pushing for good active transportation in your community so that those who could do it can do it. I do appreciate that some jobs, I mean, I know from the environmental health officers I've worked with here, who sometimes go by different names. I find the titles change in different, I think public health inspectors is used here more, but that people have to be on the road a lot. I mean, I think that's different, but I think what we're talking about is like working with our municipal partners to see when we can improve active transportation. And I will give you one example. Like in Sudbury, they had, oh, we have to go soon. They had the environmental health officer was commenting on an environmental assessment that was being done for the highway that was cutting right through the city of Sudbury. And he actually kind of pushed questions in and fought to get a tunnel that would go under the major highway so that people could actually ride bikes and walk from one side of the city to the other. Because before that, the Trans-Canada Highway was kind of intersecting the city. And so that came not from a health promoter, but that came from an environmental health officer looking at an environmental assessment. So I think it's kind of looking for opportunities to raise those issues in your work.
Definitely. And we do just have one comment from Aletta. The federal government has really good funding for reducing greenhouse gas emissions and heat pumps for owner-occupied homes. However, rental units are excluded from a lot of the funding, potentially increasing some health inequities. Yeah, that's a great comment.
That is a great comment. And I will just say, I did say later that we did a letter from all the public health associations across the country, and it was actually exactly on that point. We were saying that that the government's doing a great job, but they're kind of leaving low-income housing and low-income populations out, and that we were kind of arguing that they need to really target that group. And all the public health associations did sign on to that, so that's wonderful. I think that's a really good point.
Well, with that, it is just after 1, so we'll end here. But thank you so much again, Kim, from CIPHI Alberta branch, and we did open it to all of our members federally. So thanks everybody as well for attending, and happy Environmental Health Week.
Thank you very much, Amanda. You guys take care.
You're welcome. Take care, everyone.
Thank you.